Hi, my name is Joey Frankie. I'm a student physical therapist at the University of St. Augustine. What brings me to What's your name, Matt Mitt?
I'm Matt.
You're Mitt Matt. How old are you, Mitt Matt?
I'm 35 years old.
35-year-old male.
I'm not a male, excuse me very much.
Okay.
I'm actually a female.
Okay. What,
No, I'm being serious. I'm not kidding. 35-year-old diabetic female.
For
Not
Matt?
I'm not joking, yes.
A female is named Matt. Okay.
Yes.
Is this your right or left hand? Or wrist?
You don't even know why I'm here.
Why are you here, Matt?
2 weeks ago, I was at work and I fell backwards and I landed on my left hand.
2 weeks ago, fell on your hand?
Yep.
Whoosh. Okay. Which hand is this?
My left hand.
Left hand. Okay. Has it gotten better or worse or the same since 2 weeks ago?
Well, it was stiff and sore the morning after I fell, and then it got worse, and then it got better.
Interesting. Okay. Have you seen a doctor for this?
Yes.
What did the doctor have to say?
UEFI 51 out of 80.
Okay, so that's upper extremity functional index, 51 out of 80. Okay.
Physician referral states eval and treat for pronator teres syndrome.
Pronator teres syndrome. Doc says this. Eval and treat. All right. Is that it?
Mm-hmm.
Is there any imaging?
There is. It says see attached. I'm opening it up right now for you. There's 2 images.
So I'm looking at imaging here. Not sure. Maybe it looks. Axial T2 MRI of the wrist reveals an area of increased signal intensity surrounding the median nerve. Okay. Interesting. Okay, can we proceed with our history, please? Okay, so the imaging showed that there's increased signal intensity around the median nerve. All right, so if you could describe the location of your pain, where would you describe your pain?
Over the volar wrist.
Volar wrist, on which side?
I don't know what volar wrist is, so I can't even tell you.
Okay, it's palmar.
Currently feeling a constant deep ache over the volar wrist with intermittent burning in the palm and middle index fingers by midday.
I was about to ask you about burning, tingling, and numbness. So you're saying burning and tingling, you said?
Constant deep ache over the wrist, intermittent burning in the palm and fingers by midday.
Okay. What makes that happen? Like what brings on the burning and tingling in that palm?
Typing at work.
Typing at work. What do you do for a living?
I apologize. Sometimes there's also numbness and tingling in the left wrist, thumb, and pointer finger on the palmar aspect.
Thumb, index, middle.
Pointer. Why do you think I'm joking? In the left wrist, thumb, and pointer finger.
Okay.
And the palmar aspect, right middle.
Index, whatever. Okay. All right.
That's this.
Okay, moving on. So,
What did you say? What makes it better? What makes it
Makes
worse?
it worse.
Is that what you asked me?
yes.
What makes it better is rest. What makes it worse is like typing at work and then using my arms to get up out of a chair.
Worse. Typing and getting up from chair with hands. So if you were to grade your pain right now, what would you grade it? 0 is just not there. 1 is just barely there, and 10 is so bad you have to go to the hospital.
A 2.
Right now is a 2. What
Yeah.
about it at its best?
1.
Okay, and then what about at its worst?
4.
Okay, so we talked about what makes it better or worse. Is there any warmth or swelling?
Yes, there is some swelling.
Swelling. Where is the swelling?
Roller wrist at the left base of the palm.
Okay. Swelling at roller wrist and palm. Okay. So we figured out that the mechanism of injury was a fall on an outstretched hand. Description of symptoms, got that. Location, got it. Burning, numbness, tingling. I got better, worse. Has it gotten better, worse, the same? You said first it got worse, then it got better. Okay. Have you ever had this injury before?
No.
You ever had physical therapy before?
No.
Have you had an injury anywhere up at your wrist, at your elbow, or at your shoulder before?
No.
The symptoms, you had mentioned something about the symptoms being worse during the middle of the day, you said? Is that correct? Is it worse at the beginning of the day, middle of the day, end of the day?
There's like an intermittent burning by midday.
Okay. And is that due to work, you think?
Probably.
Do you have any unexplained weight loss or weight gain?
No.
Fevers?
No.
Chills, night sweats, bladder dysfunction, gastrointestinal, like stomach issues?
No.
History of diabetes, cancer in the family?
Yes. I have type 2 diabetes.
Type 2 diabetes. Do you have any thyroid disorder?
No.
Are you taking any medications?
Yes, I am on glucophage.
Is that
Just
for
for my
diabetes?
And I'm on naproxen for pain.
Naproxen. Okay. All right. So you said you type in what did you say your occupation was?
I am a computer programmer.
Computer programmer. Okay. How does this affect? You said when you type and get up from a chair at work, it's giving you problems.
Yeah, I'm getting really behind at work because I'm just getting bad ache when I'm typing. It's causing some tingling into my index and my thumb, so I have to take a lot of breaks.
Okay. Are there anything else that you like to do?
I'm pretty sedentary. I play computer games.
Okay, so there's no other hobbies that you like to do that are more active, maybe?
Nope.
How is it affecting you playing video games?
Probably hurts.
So are you able to or unable to?
I don't know if it just says. Just with hobbies or computer.
I'll just say able to with
I'm
pain.
able, but it hurts.
Able with pain. So before this, so currently it's looking like you had some current level function. Having some pain with at work, having some pain playing video games, and having some burning and some tingling, and always a deep ache constantly. So that's currently, but prior to this, did you have any issues?
No.
Okay. Tell me about your home. Are you having any issues at home, like with holding a cup or putting anything in and out of the cupboards, anything like that? Okay. All right. What are your goals for physical therapy?
To be able to work and play video games without pain.
Work and video games without pain. Okay. So I'm just going to review everything here with you and let me know if there's anything that you'd like to add or that I haven't covered already. All right. So you are Matt Mitt. You are a 35-year-old female, fell on outstretched left wrist. You're having pain in like the palmar aspect of your hand, getting numbness, tingling into your thumb and index finger, and typing at work is giving you issues. Playing video games is giving you issues. You're able to do both, but you're doing it with pain, getting behind at work. You have some swelling on the volar aspect of your wrist. It first got worse and it got better. And you have type 2 diabetes, taking medication for diabetes and for pain. You're a computer programmer. Constant deep ache. Currently a 2 out of 10. Pain best is 1 out of 10, and worse is 4. Is there anything else that you'd like to tell me that you think would be applicable?
I just want to make sure there's intermittent burning in the palm and the index finger.
Yeah.
And there's tingling in the wrist, thumb, pointer finger.
Okay.
Also, every other time you have asked me if I've had any night pains, and this time you didn't, and I do.
I thought I asked you about night pain.
I know, maybe you did and I missed it, but the numbness and tingling says wakes me up at night.
Numbness and tingling at night. Wakes up. All right. All right. So my hypothesis is median nerve entrapment at the carpal tunnel. The doctor thinks it's at the peroneal arteries, but I guess that'll be my second hypothesis is at the peroneal arteries with the median nerve. This is due to the burning, tingling, numbness in the volar aspect, palmar aspect of the hand, and the index and thumb finger, and possibly even the middle finger. Getting up from a chair would stress the nerve by compressing it and also putting strain on it, stress on it. So definitely median nerve entrapment at the carpal tunnel, and then I'm going to differentially diagnose that by median nerve at the peroneal arteries. So I'm going to perform the following steps. So I'm going to perform I want to do, let's see here, MMT. I want to do an MSTT before I do an MMT. I want to do an MLT for the peroneal arteries, then MMT, and then I want to do special tests. And before special tests, I want to do a neurovascular assessment. So MSTT, MLT, MMT, neurovascular, and special test.
Sounds awesome.
Let's go.
I'm ready.
So let's do this. So MSTT, so my MSTT, some muscles here in the hand. So if I could see your hand right now, perfect. So I'm going to do some the muscles that are innervated by the median nerve are the, okay, so if we're thinking pronator teres, okay, compared to the carpal tunnel, I'm going to want to do pronator quadratus. So I want to have you resist in pronation. So this is what pronation is. Okay, so if you could just kind of try to do that right now, just to resist these two fingers here. Good. So that, so what does MSTT say? Actually, I'm gonna finish this. Okay, so then I want to do, so that's for pronator quadratus. I want to do flexor pollicis longus. So for flexor pollicis longus, this is flexion. So I'm going to just have you just resist these two fingers here. Good. And then I'm going to do flexor digitorum profundus. So flexor digitorum profundus goes to the middle finger. So I'm going to have you flex the wrist, flex the finger, and then just resist these two fingers, please. Excellent. Then I'm going to have you, let's see here, median nerve. So lumbricals, I guess that's for MSTT still. Flexor pollicis longus, pons pollicis, adductor pollicis is ulnar nerve, abductor and extensor is for radial nerve. All right, so median nerve is flexor. Did that. Okay. So what I'm going to do is I'm going to do some. Can you tell me what MSTT had to say?
All strong and painless.
All right, moving on to MLT. So for MLT, I want to do a muscle length test of the pronator teres. The pronator teres does pronation, so I'm going to do supination and an extension of the elbow. So that is a muscle length test of the pronator teres. So I would compare bilaterally. So this is how I'm obviously doing on the unaffected side first. So this is her right side as opposed to her left. So I would measure pronation. So, pronation, or supination, I'm sorry. Supination is measured with these gonies. So if it's like this, the ulnar styloid, and you go into supination, this falls down. So this would be 78 degrees of supination. And this is 0. This is 78. So the fulcrum is in line with the radial styloid. The moving arm is perpendicular with the ceiling, and then, the stationary arm is perpendicular with the ceiling. Moving arm is in line with the wrist as it goes down on the wrist like that. So that's muscle length test of the pronator teres. So that would aggravate patient symptoms if it was due to pronator teres syndrome, or median nerve and tract of the pronator teres muscle. So I don't believe I would muscle length test any other muscles at this point. So can you tell me what the MLT says?
It says, unable to test secondary to muscle guarding at the wrist, incomplete tests. Supinator and pronator teres / quadratus are normal.
Okay. Test the supinator because that's the reason there. Whatever. So at that point, so you said pronator teres was normal?
Yes.
Supinator and pronator teres and quadratus are within normal limits. Okay, so that tells me what I need to know. So MSTT normal within normal limits. MLT pronator teres. Okay. Boom. MT. So now I'm going to do some MTs here. So at this point, I'm going to test the strength of some muscles in your hand and your wrist. Okay. I'm going to do pronator flexor pollicis longus. So flexor digitorum profundus, I meant to say. So again, wrist flexion and middle phalanx flexion. So I'm going to have you hold that position here for me. I'm going to provide some resistance, okay? So on the count of 3, I want you to resist this, okay? 1, 2, 3. 5 out of 5. That's pronator. Did you have any pain with that?
No.
That's flexor digitorum profundus. I need to do pronator quadratus. So I am going to try to pull you into supination, and I want you to hold yourself into pronation. Okay, so first I want you to just kind of do this first. You fan with that?
Mm-mm.
Okay, so I'm just going to try to hold this now. Okay, ready? 1, 2, 3. Strong, 5 out of 5. That's pronator quadratus, flexor digitorum profundus. Now I'm going to do flexor pollicis longus. So you do this motion with your hand for me, please. Okay, perfect. So I'm going to have you hold it in that position. I'm going to try to pull it out, okay? All right, so make sure you resist this, resist my pressure. 1, 2, 3. Strong, 5 out of 5. Do you have any pain with that?
No.
Again, I'll be performing this bilaterally. So I'm performing on the right side, on the affected side first, and perform on the left side, the affected side after that. Then, so those would likely be weak at that point. Then I would test the ulnar nerve. So I want you to move your pinky out like this. Out, like to the side.
I'm trying. That's the best
There
I
you
can
go.
do.
Okay, hold it there. I'm going to try to provide some resistance there. 1. Ooh, a little crack there. Okay, so abductor digiti minimi is strong. So I'm going to have you flex your pinky finger now. Good. So we'll hold that in there. Flexor digiti minimi is strong.
Digiti minimi. Oh,
And
that's cute.
And then I want you to, this is called opponens digiti minimi. So you go across, sort of like when you're going to touch your tongue. Excellent. So I'm going to have you hold it there. 1, 2, 3. Give that a 4+ out of 5.
Not strong.
4 out of 5 for opponens digiti minimi.
Digiti wiggity.
Yes. Good one. Very good. Very good. Classic. Then I'm going to have you do adduction. So the adductor pollicis also innervates the ulnar nerve. So maybe you go into adduction right here. So actually, I'm sorry, adduction is like this. There you go. So I'm going to try to get my fingers underneath there and pull out. Ready? 1, 2, 3. Excellent. So that should be strong as well. So that's innervated by the ulnar nerve, not the median nerve. I'm just going to do one on the extensors. So maybe just extend the thumb like this. Just go back. Perfect. So just hold that there. Good. And that's innervated by the radial nerve. So Good. So MMT information, please.
All muscles are within normal limits except wrist flexors.
Sit.
Pain at volar wrist with moderate resistance.
Wrist flexor weakness doesn't give any numbers.
Extensors 5 out of 5 in modified position to accommodate for limited wrist extension. 3+ out of 5 for opponent's pollicis. Abductor pollicis.
Opponents. Pollicis is 3 out of 5, right?
3+ out of 5 for opponent's pollicis and abductor pollicis.
Abductor. Okay.
And then 4 out of 5 for adductor pollicis.
And then adductor pollicis is, you said 4 out of 5?
Mm-hmm.
Okay. Adductor pollicis 4 out of 5? That's not.
Adductor pollicis 4 out of 5. Right for all wrist and hand are 5 out of 5. Grip strength on the left is about 15 pounds.
Okay. Okay. This is a flawed case.
Okay.
Unless adductor pollicis is dually innervated. All right. Well, that's MMTs. Now I want to do neurovascular testing.
Okay.
So for neurovascular testing, I want to do this. I'm going to do the Tonell's test at the carpal tunnel.
Okay.
So I'd be tapping at the carpal tunnel for 30 to 60 seconds. I'll do it for 60 seconds. Okay. That it has been 60 seconds. I can also do the special. Well, that's it. I'll do that later. Special test. Tonell's could technically be a special test as well. Then I'm just gonna do some sensory. So I'm just gonna ask. So I'll obviously be performing this bilaterally. So then I would be asking for sensation. If there's any sensation differences on the left and the right, or on the fingers. We'll be just kind of be palpating and brushing the thumb, the palmar aspect of the thumb, palmar aspect of the thumb, palmar aspect of the index finger, and then half of the inside half of the middle finger there. And I would compare that to the opposite hand, to the affected hand. So that would be the palmar aspect of the thumb, index finger, palm, and then inside half of the middle finger. Good. So that's neurovascular. Then I'm going to perform. I guess tell me what neurovascular has to say.
Reflexes, if tested, within normal limits. Biceps, triceps, brachioradialis. Sensation is diminished in the index, middle finger, and thumb. Median ULTT reproduces symptoms into hand at 20 degrees of wrist extension. Myotomes match MMTs.
So I did sensation. Could have done median upper limb tension testing. We'll be practicing that later. Produces hand at 20 degrees of wrist flexion 20 degrees of wrist extension, right at 40 degrees. Myotomes match median muscle test, so it'll be weak flexors. All right, so good. Moving on to special tests. So if you could move the therapy dog.
He does.
So what I want you to do.
Yes.
So what I want you to do is to do this. So do this. And like this. Do that 5 times.
I don't like that.
Okay, stop. Okay, so I'm observing for blood flow. If you could open up your hand, please. Okay, so it looks see how it's pale. So I'm going to let this go in, and then the ulnar artery is going to allow that. Then I'll release the median artery. So this would show me if the median nerve, the median artery is entrapped by the carpal tunnel. So I would perform this on the right side and then the left side. So I just performed on the right, and I performed on the left. So I'm going to ask you to do that 5 times. Okay, stop. Okay, so then I'm going to let that go. Blood flow goes in there. We'll let that go. Blood flow goes in there. So positive would be decreased blood flow on the radial or on the median side as opposed to the ulnar side, on the affected side compared to the unaffected side. So I did the Tunnels test, which could theoretically be a special test. Then I'm going to do the phalans and reverse phalans. So if you could
Yes.
pay attention. So I want you to hold it this position for 60 seconds. This places stress on the median nerve. This would reproduce symptoms of burning, tingling, and or numbness, pain into the hand in the aforementioned areas. Then we're going to do the reverse phalans. I think this is actually the phalans, not one of the reverse phalans. So this is a similar concept. This is putting the nerve on slack, but compressing it due to the carpal tunnel by doing wrist flexion. So we'll be holding this for 60 seconds as well. If you could please read out to me the special test findings.
Positive phalans, positive reverse phalans. Is there another one that you want to do?
Hold on. Neurovascular. Need to document this. Neurovascular is sensation. Diminished index and thumb palmar aspect. Okay. Then for a special test, I performed the phalans and reverse phalans, and the Tunnels, which I technically did in the neurovascular test. So phalans test and reverse phalans test. Reverse phalans test are both positive. What about it, Tunnels?
Tunnels is positive at carpal tunnel at 10 seconds of tapping.
Tunnels test positive at 10 seconds of tapping. Okay. Is there any other information?
No.
Why did you ask if I did another one?
I don't know, because I forgot you did the Tunnels, but you did it. It was the annoying one.
Yes. Okay. So that finishes everything. That was nice, short, and quick. 34 minutes. Love that in the practical.
That was short.
Last one last night was an hour and 15 minutes. And we have 40 minutes to an eval, so that's good. Alright. So I'm going to talk about stage of condition is, I should refer back. Stage of condition is subacute. It happened 2 weeks ago, and it's feeling better, and that there's just some mild swelling. Tissue activity is moderate since the patient can play video games, can go to work, but is having pain doing that, and is having trouble doing that. Is getting behind at work. Then the subject reactivity. I'm sorry, that's subject reactivity. Tissue reactivity is say it's moderate because the pulmonary arteries, well, that was normal. MSTT was strong and painless. Weak wrist flexors. So I'd say it's moderate considering that the Tenose test occurred after 10 seconds of tapping. And because Phelan's and reverse Phelan's was also positive and was able to complete the test, but was still positive. So if the patient wasn't even able to get into the test, that'd be high. But since was able to endure 10 seconds of the tapping test, which is relatively short though, and Phelan's and reverse Phelan's was able to complete the test, but it had pain, then that would be moderate tissue activity. Let's see, what else here? Let's see. All right, so that's subject activity, tissue activity, stage of condition. Then my goals for the first day of therapy treatment would be goals for the first day of therapy and/or treatment would be maybe do some nerve glides, address the swelling that is going on due to the fall and outstretched hands. Maybe do some ice. Maybe do some E-stim. Maybe just do some ice elevation and compression. Nerve glides, like I said. Sorry, I'm tired. And then as I progress to even further on in the subacute phase into the settled stage, I'm going to do some flossing, so where I am extending both ends. So glides is where I'm just extending one or extending both this way. This flossing is doing that, but I would do it in a more rigorous way where I would be extending it and then making it worse by doing upper limb tension that way, or just by by extending the wrist, extending the elbow, and then also leaning the other direction. And educate the patient both day one and throughout the entire plan of care on pain-free ranges of motion, pain-free activities, trying to modulate what the patient does throughout the day. Maybe some different ways to work. Maybe don't keep your wrist compressed at work, as she's a computer programmer, so maybe try to avoid wrist extension, and maybe if they have a gel pad on their mouse pad, we try to avoid that, because that would provide some pressure to the carpal tunnel and that median nerve. I'd provide some home exercise program once I feel the patient is competent with doing some nerve flossing and gliding and sliding. And I would definitely try to provide some soft tissue mobilization to the wrist here. I can do some palmar sweeps to open up and stretch the ligament a little bit. And also maybe just do some soft tissue mobilization just to kind of loosen up the muscles, the ligamentous structure, and maybe into the thenar and hypothenar ear musculature as well. Could also address the weakness that I found by doing some exercises with some manual resistance, or maybe using like a rubber band to kind of provide some resistance that way. And I can maybe do some neuro rehab by kind of having the patient pick up different sized and weighted objects from from on the table and putting them into a cup, and vice versa. We doing some designs as well. Prognosis for this patient is good, considering this is a musculoskeletal pathology that is often diagnosed and often treated well with physical therapy interventions. So I would explain to the patient even before getting started that what they're going to get themselves into is me performing a bunch of tests, a handful of tests to roll in, roll out the pathology, and trying to figure out what's wrong so that they know what they're getting themselves into. I would also, explain to the patient that although this may be frustrating now, and they've been dealing with this for 2 weeks, and they're getting behind in their studies or in their work and difficulty playing video games, that they will return to normal function. It's just going to take time, and we have to buy in and really work together as a team. So really try to make sure the patient feels better after the first day, after we kind of moving around the nerve and the thumb and all the muscles around, maybe possibly aggravating it, so that they want to feel excited about coming in the next day. So that would be my plan of care and explanation.